All right, welcome to our final session of the Biochemical Genetics Laboratory Lecture Series, sponsored by the Society of Inherited Metabolic Diseases, as well as the Children's Hospital of Colorado. Over the past two lectures, we've explored plasma amino acid analysis and acylcarnitine profiles. Today, we're going to complete that metabolic trifecta with urine organic acid analysis. This is arguably the most complicated assay in the Biochemical Genetics Laboratory and one of the most challenging to interpret. So as with the rest of this series, the goal is not to catalog every metabolite or pathway, but we're trying to build a practical understanding of the testing methods and limitations while learning to recognize meaningful patterns in metabolic diseases. Today, we're happy to say that our lecture will be presented by Dr. Anna Scott, a wonderful biochemical genetics laboratory director at the Seattle Children's Hospital and an assistant professor of laboratory medicine and pathology at the University of Washington. So over the next hour, Dr. Scott's going to walk us through the principles, pitfalls, and clinical utility of urine organic acid analysis. So with that, please take it away, Dr. Scott.
Thank you so much for the introduction, Marcus, and thank you everyone for being here and showing up. We are fortunately through University of Colorado, we're able to offer CME. So at the end, please enter this code. Christy will also copy it into the chat box for easy access. You can text that code to the number displayed or enter it online. Thank you, thank you. So as Marcus said, this is part 3 of a series that we hope you've enjoyed. The goals here, as Marcus said, was to overview the testing and really highlight some common concepts through cases. So today I will be diving into urine organic acid analysis. I do have the chat box up, so feel free to enter in questions. My colleagues Marcus and Ashley may respond in real time, or I will review questions at the end. So our learning objectives today, I really wanted something broad because every case is a little bit different. So I'm hoping by the end of the lecture, you can describe the role of urine organic analysis in the diagnostic process for inborn errors of metabolism. And really what you deal with first is on the medical side is the report. So be able to compare and recognize the different reporting styles offered by the various laboratories. We have qualitative and quantitative styles of reporting organic acids. And then I'm hoping, again, by the end of this, you can be aware of at least 2 method differences that may exist between different performing laboratories. There are many differences, and this can impact how different metabolites, different compounds are detected, and their kind of relative significance. So those are our learning objectives today. And so I'm going to dive right into it. Why does urine organic acid analysis matter? Well, it is the third piece of the metabolic trifecta when we are working up a potential inborn error of metabolism. We've got our plasma testing in amino acids and acylcarnitines that were already described in previous lectures. And organic acids is the urine test that really complements this blood testing. I love it because it's an untargeted assay. Sometimes, and I'll show you through some of the case examples, it can provide clinical context and clarify abnormalities that we observe in the plasma testing. Urine organic acids, while it is not a speedy test, it absolutely can be expedited. If your testing is available in-house, it can 100% support urgent decision-making around care, whether or not you can provide protein, just kind of what pathway of abnormalities you're dealing with. Urine organic acid testing can be extremely helpful and informative. And as we see here in the picture, it is a beautiful complement to our blood testing, and it can help to distinguish between overlapping presentations. I think one of my favorite parts of urine organic acid testing is it can also really guide confirmatory. Even if I can't say, this is your genetic abnormality, sometimes we can put it into a bucket of like, we're down to a couple of genetic options. That can guide next steps and being efficient with your resources, whether that is additional add-on testing or limited draw capabilities because your kiddo is really small, you can guide those next steps and make it as efficient a process as possible. So what are organic acids? These are small carbon-based molecules. They are readily excreted in urine. Many of the ones that we think of associated with classic disorders are really derived from a catabolic process. The breakdown process of amino acids are some of our big hitters in the textbooks. But ultimately, they can be derived from a variety of pathways. In some cases, we're really lucky, and some compounds are pathognomonic to pinpoint a genetic disorder. Less times, they're fuzzier. They can point us in a general category. And I want to highlight here that when we're talking about urine and organic acids, many of these organic acids, they like to conjugate to glycine. And so this is part of why urine organic acid testing is a really wonderful complement to plasma acylcarnitines, where carnitine is your FedEx of the body. It helps move those small organic compounds in and out of cells, and you've got something, the carnitine conjugate. Example here, isovalerol carnitine. If you want to excrete isovaleric acid in urine, it will often conjugate to glycine. So glycine is our UPS of the body. It goes to the urine. So your carnitine conjugates will often produce a corresponding glycine conjugate in our urine. And the way we test urine can provide us with more specific compound identification compared to acylcarnitines. And I'm going to dig into that in a few more slides here. But anyway, I wanted to highlight that connection between our acylcarnitine profiles and urine organic acid analysis. Okay, I mentioned there's a lot of pathways that we can see with urine organic acid testing. And this was just kind of a quick review. Dr. Carlos Ferreira has been working for the last few years in collaboration with a number of other folks to build out this international classification of inherited metabolic disorders, basically an updated published version of some of the way we think about inborn errors of metabolism from Soderbray's textbook. But this was just me off the cuff, adding arrows to the categories that we can see in urine organic acid testing. This is by no means comprehensive, but I wanted to highlight we can see a lot. This was untargeted testing before metabolomics was a hot topic. Urine organic acids was here in the clinical lab supporting metabolic disease. And we very well may see a lot more in the mito realm. I don't know if you can see my mouse here, but upper red part of this diagram, there's a good chance we will see biochem markers in urine, likely nonspecific, but basically the stuff that I've highlighted here are things that I know for sure we can see something, and we are still learning all the time about abnormal metabolites that are accumulating. What do they mean? Where can they come from? How are these pathways interconnected when in the setting of a genetic abnormality? So this is why I love urine organic acids. It's a big overview of potential pathway disruption. Now, urine organic acids are tested in a wide number of labs, and you may have noticed your favorite lab may have different sample requirements than the next lab over. And this is because specimen requirements are actually kind of challenging. At the end of the day, all of us in the laboratory, we want to make the most of whatever samples we get. And so we have almost the majority. I want to highlight here, this was in 2024, the SIMD lab director working group rolled out a series of a survey to clinical labs asking a whole bunch of very nuanced questions about methodology. And this is a figure that I've pulled from a fellow here at the University of Washington will be presenting those survey results at SIMD in a poster. So I hope to see you there in a few weeks. This is one of the figures. And almost the only rejection criteria that there was a near consensus on was if a urine sample is visibly contaminated, we will reject it for testing. Beyond that, most labs will do their darndest to test whatever comes in. Even if it's extremely low creatinine, even if the storage conditions were suboptimal, most of us will take most of whatever you can send. And the reason for that is that sometimes even with a suboptimal sample, we can still make a diagnosis. And that is really important. What I've got pictured here on the right of this slide is a pair of urine samples that were collected on the same day from a newborn. This newborn had flagged newborn screen for elevated succinylacetone. So the question and the concern was tyrosinemia type 1. The first sample that came into my lab was a short volume. It was less than 2 milliliters of urine, and it was very dilute. So we were only able to extract about zero point 0.1 milligrams of creatinine. For our method, we like to target 0.7. So this is a seventh of our target ideal urine amount. And yet highlighted there, we could clearly see abnormal excretion of succinylacetone in combination with the elevated tyrosine and the plasma amino acids. Slam dunk, we've got our diagnosis. We could plug that infant into care, get them on the clinic schedule, get them connected to the appropriate resources. Unknown to me at the time, the family was warned the sample might be considered insufficient volume, so they were sent home with a urine collection bag. And subsequently, an additional 8 milliliters of urine, very, very similar concentration, came in. We were able to extract that and see the exact same signal. It was much more bold, as you can see in the bottom picture. But this was a really beautiful example of why, even a short volume, apparently low creatinine, if we can glean something clinically significant, lab directors hate to reject that specimen. We'll give it a shot. We'll see if we can find whatever is relevant for the clinical question. So there are very few hard rejection criteria for urine organic acid testing because sometimes we see something that matters. Here's my general picture of, okay, what is happening with that urine? After we receive it, there are a variety of steps that happen. I would say the vast majority of labs, I think it was over 80% of labs, perform urine organic acid analysis on a GC mass spec. So that is what is pictured here. There are a smaller fraction that use other kinds of instruments. I would say LCMS is one of the newest kids on the block, so that's tandem mass spectrometry. It has some strengths. I'm not going to talk about it a whole lot in this lecture, just because that is more of an exception than the rule. Now, to process that urine and get it ready for injection into a mass spec, there are a large number of steps that happen. And it seems the general themes are consistent between labs, while the details vary. So some labs start the process with an oximation step. This is actually an early derivatization that stabilizes keto acids, that increases the sensitivity for some of our favorite compounds like succinylacetone and pyruvic acid. However, this takes extra time. That means extra resources, extra manpower. And most of the time it doesn't change the interpretation. Without oximation, could we have seen the succinylacetone in that previous example? I'm not sure about the first sample that was very short. I would hope we would have seen it in the second sample where we had more volume. Hard to know for sure. But plus or minus oximation is a significant difference between different lab procedures. Urea is the most common compound in urine, not surprising. That means that there is a lot of urea interference that we need to wrangle. Some labs address that by adding urease. You can add sodium sulfate as a way of dealing with the urea, but basically we need to help remove that and prevent ion suppression later down the road. So making sure we're pulling out the interesting metabolites and leaving as much urea behind as possible. There are acidification steps, and then you get to the fun part of the organic extraction. Again, majority of labs do a liquid-liquid extraction. There are some variations. Some labs do a solid phase extraction. In any of these, you're using some sort of an organic solvent. Ethyl acetate is the most common. Ethyl ether is used in some labs. And there's typically somewhere between 2 and 3 rounds of organic solvent applied to basically water, our urine specimen, to pull those small organically soluble metabolites out of the urine and basically clean it up and leave behind all the junk, hopefully a lot of the urea. Once you do those multiple rounds of organic liquid-liquid extraction, there's typically a dry down step. And then about the only step that there is 100% concordance across all performing labs. We all use trimethylsilyl derivatization. We're adding a bunch of positive charge to organic compounds to make them easier to detect. Okay, we've derivatized. We now have a much smaller volume that is concentrated metabolites extracted from that urine sample. That sample is then injected into an instrument, and the runtime varies, but based on the performing lab. But most labs run, each sample takes about 30 to 60 minutes, depending on their instrument settings. So you can never get an organic acid stat because the instrument time is already greater than the minimum turnaround or the maximum turnaround time for a true stat order. And the pre-processing is going to depend on the particulars of the performing lab. Realistically, this is a few hours, but it can be done in a day. So this is why communicating with your testing lab, letting them know that this information is really important for medical management, can make a really big difference on that turnaround time. I do want to highlight, if you ever have questions about more details of methodology, there is some really thrilling reading linked at the bottom of this slide. Okay, let's talk about the data. What comes out of the mass spec? Well, we're not yet at the point of writing a report. This is the data as it's displayed. And what we're measuring is the metabolites that are eluting from the column over time. And how much is there at any point in time? So this particular display, the x-axis is time, and this, you'll notice it kind of goes down to a second line, but those numbers ranging from 6 to about 25 are all in units of minutes. This is taken from my lab's instrument, and the y-axis is abundance. Think of it as intensity. So as we march along, stuff starts coming out of the column. So we've injected our urine sample, it gets heated up, it passes through 25 meters of a gas chromatography column, it comes out the other side and slams into our detector and is recorded. So at about 6.5 minutes, we have one of our internal standards, caproic acid, pictured here. More time passes, we get other metabolites coming out. I wanted to show you this as an example of a very normal urine organic acid profile. Now, you'll notice some of these peaks are labeled with text and some are handwritten. Our computers have varying quality of compound identification, particularly since some of these peaks may not be 100% one compound. So this data is actually three-dimensional. And what's not displayed here, because it doesn't print out on a printer easily, is that third dimension, which is the fragments, the mass fragments present at that point in time. So we manually inspect each and every peak and look at the mass fragmentation pattern. We look at the retention time, and with those pieces of information, we can correctly identify a particular compound. So this is an example. I know as a lab director, it always makes me really happy when a compound has a really distinctive characteristic fragmentation pattern. So this is actually one of the internal standards that we use in my lab. It's called cyclohexylacetic acid, but you'll notice it has really 4 dominant fragments. So this is now, x-axis is a mass fragment, M over Z, y-axis is still intensity. So we've got fragments here of 117, 132, 199, and it's always in this characteristic pattern or relative ratio of these fragments. Another example, benzoic acid. I kind of think of this as almost like a little kid's slide with a hump in the middle. So there are these visual characteristics of some compounds that make them very easy to spot. And again, we're also looking at the particular retention time on our instrument to help with that identification. But these fragmentation patterns can look can be highly variable. So here's adipic acid, another common friend in urine. Primary signal is this guy right here. I don't know how to describe that, but it's a characteristic little kind of I don't know, loop-de-loop of mass fragments. And those masses are conserved. And again, the relative ratio of these guys should be very steady. It gets confusing when things coalute. And also, some compounds do not have really pretty, clean, unique masses. So it is essential for each laboratory to establish a local library of metabolites that reflect their methods and their instrument parameters. Uh, I'm going to show you here a series of compounds where the retention time, abbreviated RT, is absolutely essential for correctly identifying these. So glycolic acid, normal urine metabolite at low abundance. It comes out early in our system. Notice we've got the same mass fragment of 73 and 147. Sometimes some smaller stuff is helpful, but it can be lost in the grass of depending on the intensity of the peak. So we've got glycolic, we've got oxalic, we have methylmalonic, one of our favorite friends for diagnosis. We have ethyl hydrocrylic, less unique, also sometimes very important. Ethylmalonic, super important sometimes. Notice our friend succinic has the same set of 73, 147 and its close neighbor methylsuccinic. So this is not, again, not a comprehensive list, but I wanted to show you the similarities that can be hazardous when trying to identify a compound. And this is why the full picture, the masses, their relative intensity, and the retention time, and the local expertise of your lab, their familiarity with these compounds is really important for correct identification. It can make all the difference in the interpretation. Because many patients are not normal, and there can be a lot going on in a urine sample. The previous urine that I showed you was normal. This is not normal. These are some features that I interpreted as mostly reflective of clinical status. So we definitely had some evidence of ketosis going on. There was MCT oil, high calorie infant formula was being provided. This kid was in a tight spot. There was TPN going on. There was liver immaturity. But as we wade through all of these peaks, we can sort through and pull out things that are diagnostically important. And so this is why each and every peak does need to be looked at. As we've trained new techs in my team over the years, there's always been this question of like, well, is there a cutoff when we don't need to look at something by hand? And the unfortunate answer is almost never no. There's not a hard, pretty cutoff of you can ignore it if it's below this amount. The previous example, small, minimal amounts of succinylacetone are extremely clinically important. And here we had, there's all of the slash marks indicate that that was something in this urine sample that was extracted and does not match anything in our library, unable to identify. Probably a combination of endogenous compounds, probably a mix of medications. But in that mess, we've got stuff that tells me a little bit about the clinical status, but we also have all of the yellow highlights point to a specific genetic abnormality. And in this case, this was methylmalonyl-CoA mutase deficiency, classic MMA. So the job of the lab director is to wade through all of this to make sure that we don't miss something. And sometimes that can be challenging. When we look at the total ion count, so this is the thing that in my lab prints off first. Sometimes peaks are nice and pretty, but sometimes buried underneath, there can be something sneaky. So this is actually a zoom in picture of that peak at 15 minutes where I've extracted particularly relevant ions. And what I want to highlight here, we're going to revisit this particular peak in a few more slides, is the red and green lines. Sorry for anyone with color blindness. Those are the two big ones. So here's the red trace and the green trace. These are coming out at the same point in time. And that time is slightly shifted from the black and blue trace. So I'm going to actually go back. This looks like a relatively smooth peak. It has a little bit of a tail here, but that may or may not mean that there's a second compound underneath. In this case, there is absolutely a second compound underneath that peak, and it is extremely clinically important, as we will see in a couple more slides for one of my cases. So we want to do careful inspection, particularly looking for sneaky pathognomonic compounds. After digging through all of the grass, maybe a bunch of clinical noise, and turning that into a report. So something, this should be a little bit more familiar, hopefully to most of you, of what you see that is sent back in the medical record. There are different reporting styles. There are some reports come back fully qualitative. And what I mean by that is there are no numbers. It's just a bunch of words. And I've got an example here that I did for a sample where we were unable to accurately quantify the creatinine. And it turns out this was a patient with alkaptonuria, and we missed the appropriate dilutions to confirm the creat. That's a different can of worms. But you'll notice it is all words, and we can have a description, but at the end of the day, there should always be an interpretation that says, what does it mean? What was the lab detecting? And is that consistent with either a known diagnosis, or is it suggestive of a new diagnosis? This, I would say most of the time, that is plenty of information, particularly if you're using it for diagnostic determination. Most of the time, my team reports a semi-quantitative report. So a short list of metabolites where we run semi-quant. This is not like your drug monitoring labs where you've got high accuracy quantitation of that compound in your fluid of choice. This is fuzzier because urine is fuzzy. It varies in concentration, it varies in interference. We do not have heavy isotope internal standards for every single metabolite that we might be able to detect. They're not commercially available, and it would also be an insane amount of work that most of the time doesn't matter. So typically in the setting of semi-quantitation, we are looking at the intensity of that signal that corresponds to that metabolite, comparing it to a set internal standard. And normally that internal standard has a consistent area under the curve. So we use that to normalize and say, okay, this is normal, or this is elevated. So pyruvic acid could be normal at 32. If the area is double, it might be right at the upper edge of normal at 60. These numbers should be taken with a big grain of salt because they are fuzzy. I think some labs, particularly ones that are using tandem mass spectrometry, are leaning more towards fully quantitative. Again, there's no way they've got heavy isotope version internal standards for every single possible metabolite they can detect in their methodology. But LCMS, tandem mass spec, will be more accurate in terms of a quantitation. So those reports are likely to look a little different, have a lot more numbers and components reported. Whether there are numbers or not, the report should always include an interpretation of what does this mean? Because it can be a lot to wade through, and there, as we've seen, there can be confounders from clinical status. So know your net lab, be prepared for a variety of reports, and feel free to ask questions. I just wanted to briefly highlight here, and I'm about to transition into case examples that highlight all of this fun stuff. But the data processing side is different laboratory to laboratory. Some labs have semi-automated methods for targeting known troublemaker compounds. Sometimes they have checklists, and a person is manually checking for those troublemakers every single time. My team does a combination of, we have a little macro that looks for the troublemakers, but it is also manually inspected. One strategy can be that you're semi-quantifying those troublemakers every time to make sure that you're looking really carefully at those areas of the profile where you know things can be sneaky. And as I highlighted, there are not heavy isotope commercial internal standards for true quantification for all compounds. Some are possible, some are not. And also even just commercial standards, there's a lot of stuff that we can see in urine that does not have a readily available commercial compound. We're often able to identify it through repeat analysis, comparing notes with other labs of like, hey, have you seen this? We've got a whole mess of peaks that are annotated as valproate metabolites, where I couldn't tell you exactly what that chemical structure is. I just know we see it whenever a patient is taking valproate. and it is a hot mess. So those are some challenges for local library curation, but participating in proficiency testing, sharing notes, and being open to learning is a great way for labs to continually improve the diagnostic sensitivity and specificity of our urine organics. So with all of that as a method background, now let's jump into the fun stuff, the case examples. This is an infant, case 1, referred for an abnormal newborn screen for elevated C3. Kiddo was at home at time of the newborn screen result call out, so presented to the emergency department for evaluation. I'm not going to read all this stuff, but the basics are starting to develop clinical concerns. We've got an elevated ammonia at 400. The ED, their evaluation was that the kiddo was slightly hypothermic. There was mild bradycardia, mild lethargy, particularly after feeding. I do have the chat up. So quick, what's our differential diagnosis at this point for an elevated C3 with hyperammonemia? Go. Give you 10 seconds. Note, acylcarnitines. Propionic acidemia and MMA. Yes, full points. So we are concerned about elevated C3 and our classic inborn errors of metabolism, methylmalonic acidemia and propionic acidemia. From our acylcarnitine, we can see we have very low carnitine. Our C3 is elevated at like 20 times normal at 18. We can't tell from here which one of those two it is. Urine organic acids to the rescue. Woo-hoo. And this actually is the corresponding organic acid for this patient. So for the most part, not in as tight of a spot as the MMA that I showed you earlier, but we do have very dramatic elevation of 3-hydroxypropionic. That's the first highlight in the upper section. We also have very abnormal excretion here of methyl citric acid. Did I have, nope, okay. Those two findings together are pretty darn concerning. Now, our methylmalonic excretion is this little peak down here just after 9 minutes on our instrument. So knowing nothing else, that is enough to say, high concern for propionic acidemia. I can't tell you if it's a type A or a type B, because note there are 2 genes that make up that carboxylase, but normal MMA excretion with significant methylcitric and 3-hydroxypropionic, we're worried about a propionic acidemia. Now, the pathognomonic, well, not pathognomonic, highly suggestive confirmatory molecule here is our little friend propionyl glycine. And knee-jerk might be to assume that it's this big peak here at 11.05. That's actually an unknown compound. And our little friend propionyl glycine, which is really clinically significant, is down here in the shoulder. So if we zoom in on that peak at 11 minutes, again, primary thing, unknown. Propionyl glycine, tiny little hump on the side. But if we click on that hump, we can see very characteristic ions. So this is a unique pattern. It is a tiny propionyl glycine peak. This gives me so many hours of stress. Extracting, so we can do this process called extracted ions, where highlighting the 159 and the 188 masses, I can pull out those in particular. This can help us to separate the compound of interest from noise that's going on. And we can see these guys perfectly coelute down here on this bottom. So this is showing the retention time, the intensity, and those ions are coming out together. So it's not random chance that we had those masses at that moment in time. They're not coeluting compounds or slightly off-shifted compounds. They are, in fact, propionyl glycine. This patient had propionic acidemia, got plugged into care, doing great. Case number 2, toddler evaluated for developmental regression following a viral illness and new onset movement disorders. Patient was seen in neurology, and good job on that neurologist, ordered an acylcarnitine. That profile was horrifyingly normal, except for a really minimal elevation of our friend C5DC. This one was 0.13 micromolar with a normal cutoff of 0.12. It doesn't get subtler than this. When I looked at the chart, there was relative macrocephaly, so not actually the outside of the standard curve, but relative, and recommended immediate urine organic acid analysis. Again, quick question for our audience for participation. What disorder are we worried about here? GA1, full points. Okay, let's look at that urine. Now, a classic GA1, a classic glutaric aciduria, has absurd glutaric acid excretion. So I wanted to highlight here, we've got our internal standard. This is often the biggest peak that my lab sees at 10.4. Notice this stupid peak of glutaric acid. Normal is down here like at that 12.8 peak. That's a normal glutaric acid. This is an absurd glutaric acid. And we have a full peak of 3-hydroxyglutaric, pathognomonic here for our GA1. Easy peasy. Not my favorite diagnosis, but I love it when the organics are easy to interpret. Now here is our little friend. He is the lowest he and his siblings are the lowest excretors I have ever seen. They do have genetically confirmed GA1. Clinical course is absolutely consistent. Now notice there's our friend, the internal standard at 10.4. This is an extremely normal glutaric acid excretion. This would never pop out of a lineup. And this is actually now revisiting when I showed you that extracted ions trick earlier to find close to co-eluting compounds. This is that peak. So normally there is 2-hydroxyglutaric acid at 15 minutes. If we integrate that entire peak, this is normal looking. But if we dig underneath it, there is our very low abundance, but extremely clinically significant 3-hydroxyglutaric acid, consistent with his acylcarnitine profile, consistent with his clinical picture. This is a GA1. Sneaky, subtle, stresses me out. All right, case number 3. This was an infant who flagged newborn screen for elevated C8. And this kiddo was a very difficult blood draw. Fortunately, they got urine, so they went ahead and they submitted that urine sample, planned to come back to outpatient phlebotomy another day for a redraw attempt. So we only had urine. Yes, real time, Dr. Bennett, they did order, sorry, I think we did urine acylglycines as a part of a research study. I think it was still borderline. And SIBs all have the 2 SIBs, same genotype, undetectable. You'd never pick them out of a lineup. Totally normal newborn screens, have also been asymptomatic. It's fun. So yes, this is MCAD. Love the audience participation here. So this was a kiddo, flagged newborn screen. We're worried about MCAD. We got this urine sample, but we don't have blood yet. This is a pattern that I would say does not pinpoint MCAD. It is definitely consistent with a fatty acid oxidation defect and 100% justifies making sure you get that blood. Actually, even with this alone, I'd say refer to clinic. They need further workup. They will need metabolic management, even if we can't say 100% this is MCAD. That newborn screen was not caused by MCT oil in a high-calorie infant formula. There is a fatty acid oxidation defect going on here. We've got enough friends, particularly that chunky hexanyl glycine and suberyl glycine. These friends down here at just shy of 16 minutes and 23 minutes. So yes, subsequent blood collection shows our classic pattern. I just wanted to highlight here because again, urine organic acids are most powerful in complement with our plasma testing. And here's a really great example. Sometimes you've got one sample type, sometimes you've got the other one. It can provide key information to justify next steps. And again, where I wanted to go with this case was saying, yes, there is a fatty acid oxidation defect. You absolutely need to get your acylcarnitine, but if the patient continues to be a tough draw, do not wait. Go straight to clinic, get plugged into care, make sure they're going to be safe. All right, case number 4. I'm really hoping Renata is in the audience because she asked this question last month at the acylcarnitine lecture. Um, Beta ketothiolase and this really fun, rare mitochondrial disease that is X-linked. I think of it as HSD10. It has many names. It's also sometimes abbreviated MHD. There might be, MHBD deficiency. I went ahead and clipped OMIM because there were a lot of names for this thing. But anyway, these guys can have similarities in the acylcarnitine profile. So Renata's question at the end was, can urine organic acid tell the difference? And punchline here is maybe. So both feature ketoacidosis and can present with hypoglycemia, brain abnormalities if that metabolic decompensation event has been severe. It's essentially white matter changes due to energy starvation. So looking at our fun friend IEM base, because I love this as a resource to tell me, okay, what might be the spectrum of things I could see in a disorder? So I tend to use this a little bit differently than my colleagues. When we pull out the expected urine organic acid profile from IEM base for beta ketothiolase deficiency, that we get a fun assortment of metabolites. There are several things we can be looking for. For HSD10, there's a lot less, but there are two characteristic friends, 2-methyl-3-hydroxybutyric acid and tigloglycine. So this is what we're looking for. Here is a beta ketothiolase patient that we saw the last few years. Upper profile is from acute illness, severe metabolic decompensation, and the bottom profile is after management. So after they'd received those emergency fluids and had kind of stabilized, the hypoglycemia had stopped, the ketosis had resolved. And I want to highlight, here are some of our friends from the list from IEM base. So we have massive excretion of ketones. That 3-hydroxybutyric is the first peak here highlighted in the box. We have very abnormal 2-methyl-3-hydroxybutyric, which is actually not listed on IEM base. And we have what I would say the most pathognomonic metabolite for this disorder, 2-methyl-acetoacetic, massive excretion. You never see this in a normal person. This is consistent with beta ketothiolase. Notice all, and there was tigloglycine, it got cut off here, but there was abnormal excretion, less so, less dramatic than these other friends. So we had 3 of them of kind of the suggested, plus an extra friend, the 2-methyl-3-hydroxybutyric. But after management, this patient fully normalized. And I do want to highlight, despite the significant excretions here in urine, acylcarnitines were normal. They had ketosis, so our friends C2 and C4 hydroxy, but otherwise a normal acyl profile. This does not help me sleep at night. Okay, here's our HSD10 friend. And this is a patient who we've tested a few times. And notice we do have the 2 compounds suggested by IEM base. We have significant excretion of 2-methyl-3-hydroxybutyric and a really lovely doublet of tigloglycine. So this is a very significant amount of tigloglycine. Often I will see little squeaker peaks of the first one. So this is the monoderivatized up here. We've got the diderivatized down here, which you get if there's enough present. So both of the suggested metabolites we can see, and this is routine monitoring. So this patient never normalizes. Those friends are always there. So also notice there's significant excretion here of ethyl hydrocrylic. And I think of this as a mito marker, may or may not be present, but was on our list for beta ketothiolase, was not significantly elevated or couldn't be dug out from the rest of the ketones and the 2-methyl acetoacetic that was present at that same kind of region of our chromatogram. So I would say these are challenging cases. Can we tell the difference by organic acids? Maybe, sometimes. Very likely patient dependent and clinical status dependent. Note, I've got really an N of 1 for HSD10 and an N of 2 for beta ketothiolase. So I think the urine organics might be able to point your bias in the direction of one gene or another. I would not feel comfortable calling a genetic diagnosis for either of these based on urine organic acids alone, um, with the exception of that first one with that 3-methyl acetoacetic, because that is so unusual. Okay, case number 5. Watching the time because I'm having way too much fun with this. We've got an infant who presented on day of life 1 with lactic acidosis, respiratory distress, altered mental status, all kinds of horrible things going on. I wanted to highlight this case because I think it really shows the power of what organics can do for us. So lactic acidosis was significant at 16 on day of life 5, ramped up to 28 at some point during admission. We were able to run the amino acids first, and based on these findings, I was very suspicious for a classic organic acidemia. So we've got massive lactic acidosis and a very chunky glycine. Both findings are quite commonly seen in a broad group of organic acid disorders. However, we got the acylcarnitines out second, and it was remarkably normal. We've got a mild flag of C4, but everything else was extremely normal, almost too normal. And so it was like, okay, we really need the organics to have a guess of what is going on here. And this is what we found. So lactic acidosis, not surprising. That's our big friend over here. Um, Through this middle section, my highlights are really going after an assortment of branch chain intermediates that if we were significantly ketotic, I would be less excited about. Because during ketosis, we're breaking down our branch chain amino acids to access fuel. In this case, there was no ketosis going on. This kid had been on IV fluids and nutritional support. And there is this really unusual peak of 2-methyl-2,3-dihydroxybutyric acid. When I go to my favorite textbook, Thought-Ubre, 2-methyl-2,3-dihydroxybutyric acid is associated with an inborn error of branch chain amino acid metabolism, our little friend ECHS1. There's another gene in that pathway, but also we're talking about valine catabolic pathway disruption. But the glycine didn't go away, and there wasn't evidence of a medication that explained it. So went to our friend, IEM base, and typed in hyperglycemia. And I got 4 genes. And then I also typed in butyrate, something that is making that 2-methyl-2,3-dihydroxybutyric acid. And you'll notice that our list here does not overlap at all. And I was like, I don't know what this kid has, but they have something. They have a metabolic disorder. It is something that is producing abnormal organic acids. It is very reminiscent of a mito defect. And rapid genome found LIAS, lipoic acid synthetase deficiency. I thought variant of NKH2, but MRS reported normal CSF glycine. The kid never was neurologically severe enough to justify a CSF tap, so we haven't tested CSF amino acids, but rapid genome found variants in LIAS. So this is a cofactor synthesis pathway that affects mitochondrial dehydrogenases and the glycine cleavage pathway. And we really needed all of the labs to put this together. And I wanted to highlight this case as a way of saying we are learning stuff all the time. No one reference has every pattern of metabolites that you might see in every genetic defect. Our patients don't read the textbooks of what their profiles should look like, and they can throw us for a loop. I'm always learning from organics. So last classic clinical presentation, I think. Oh, no, not classic presentation, but I wanted to highlight this as another one where being open to learning. Case 5, 20-year-old found non-responsive at home, unknown period of time, found to have hyperammonemia, was put on dialysis and ammonia scavengers. Hot mess of free amino acids because of that dialysis and protein restriction, very low free carnitine. More of the story unfolded. I learned that this patient was a bit of a carnivore, enthusiastic protein eater, but had recently had a shellfish feast. Question, urea cycle defect, acute toxicity from ingestion of something. And then we found these urine organic acids with 2 very important friends. We've got uracil at 11 minutes and orotic acid, which for us coelutes with a actinic acid, but combination highly suspicious for a late onset OTC presentation. I was like, we have OTC, we have an answer. And then we got thrown for a loop again. Care team did a CT scan looking for neurologic damage after the persistent elevation of ammonia, and they found raging metastatic cancer throughout his torso, in the lungs, all over the liver. And there are a number of case reports and little series that describe an unusual form of I'm not going to say that right, hepatocellular carcinoma that causes an acquired OTC deficiency. So I would say biochem testing was pointing us in the direction of late onset OTC deficiency. We don't have the final answer yet for this patient, but putting the full clinical picture together looks like this is an acquired, hopefully temporary OTC deficiency secondary to an unusual liver cancer. So these were highlighting a bunch of cases, classic inborn errors of metabolism, some that I've been learning from. I'm going to really, hopefully in the next 5 minutes, blast through these non-metabolic IEMs and leave a few minutes for questions. So newborn screen, abnormal C5. Infant was premature and still admitted to the NICU for nutritional and respiratory support. We do have elevated acylcarnitines with C5 of 1.2 micromolar. Normal is less than about 0.4. But when we do the urine organic acid analysis, we see something that's essentially normal. There's normal excretion of 3-hydroxyisovaleric, and there's no appreciable isovaleric-glycine. Together, these indicate what we have is pivolic acid interference from the antibiotics. This is a known phenomenon, particularly impacting acylcarnitine C5 measurement. This is medication interference. This is not a metabolic disorder, and the urine helps us to resolve that. Another case, adult presented with sudden onset altered mental status and acidosis. Sometimes we get this much information, sometimes we don't. This is one where the significant peaks here are lactate and massive excretion of glycolic acid. This is characteristic of ingestion of ethylene glycol. So the ethylene glycol itself, good job. Thank you. I love these chat answers in real time. Ethylene glycol is rapidly metabolized to glycolic acid. If you can catch it in the act and detect the ethylene glycol, that can be helpful. But depending on the timing of that sample collection, this may be what you see. And I would say this combination of elevated lactate and massive glycolic acid, you don't get that outside of significant ethylene glycol ingestion. Now, this is a case that I wanted to highlight as a contrast. This was an abnormal newborn screen for C3. Totally normal plasma testing. This patient does not have MMA, PA, or cobalamin defect. There's even no evidence of a vitamin B12 deficiency. But I mildly hyperventilated when I saw this ethylene glycol peak at 9.6 in our system, and in fact sent off residual plasma for ethylene glycol testing to see was it in the blood. That came back negative. I don't remember if I put in something. And subsequently, I've seen about 13 cases of this where they're neonates or infants, sometimes admitted, sometimes at home, always comes along with elevated adipic acid. And there's never detectable ethylene glycol in the plasma. So at this point, I am now convinced this is an exogenous contamination from hand sanitizer, diaper creams, I don't know, glue from the urine collection bag, something. But it is an exogenous contaminant where the blood gave us confidence that it was external. And again, I've now seen this pattern go back. Here's our ethylene glycol peak. Notice totally normal lactic, normal glycolic, and this rather chunky, unusual adipic acid. If this were a school-aged kid, I'd be concerned they were eating a bunch of Jell-O. With a newborn, they're not eating Jell-O. This is coming from something else. And adipic acid is often used as an additive to lotions and things. It's easier on the hands and prevents drying out. So I haven't been able to pinpoint the manufacturer or what it is. but it is definitely exogenous and convinced myself over time that this is true. All right, almost there. 15-year-old sudden onset liver failure with a recent fever. Uh, Here is our upper profile. What is most concerning is this peak of 5-oxoproline. But what I wanted to highlight here is while this might send us down the road of glutathione synthetase deficiency, in an individual who had previously been healthy, if we look at the full, so here's things that can have elevated 5-oxoproline. Um, but if we look at the full profile, we also see a bucket load of acetaminophen. This is what you can also see in the setting of Tylenol toxicity that causes a secondary glutathione deficiency and massive excretion of 5-oxoproline. So full context, not very unlikely to be genetic in etiology, most likely Tylenol ingestion. And wrapping this up, I love organic acids, particularly when I don't have clinical history, because sometimes I can see things that give me context and change my degree of clinical concern, or I can start to maybe make guesses of what is the question here. There are all kinds of things we can see outside of metabolites. The test is best suited for metabolite detection, but we can see medications, we can see evidence of diet features. There are all kinds of other fun things that we can see that I've highlighted here. Again, not a comprehensive list, but as a complement to our acylcarnitines and amino acids, sometimes organics can give us some context that we otherwise don't have and be like, ah, you are doing a workup for ketoacidosis. You're doing a workup for seizures because you're on buckets of seizure meds. You're having issues. Maybe there's failure to thrive. I can see MCT oil and TPN. These can be clues that can help the lab director. It is much better if we're not guessing. Please tell us what's going on. Urine organic acids are an essential tool for diagnosing inborn errors of metabolism. I hope I've convinced you of that today. But our interpretation is most powerful with clinical context. Organics can help us guess at that clinical context, but it is helpful to know. And methodology and reporting styles do vary. Let us know what your needs are. Help the lab, we will help you. We can all learn better together. We are learning about new patterns from patients and genetic diseases all the time. With that, I want to thank you all for sticking with me for an hour of organic acid chromatograms. Give a shout out to my colleagues, Dr. Ashley Stiles, Dr. Marcus Miller, for doing the amino acid and the acylcarnitine reviews. I'm happy to answer more questions and will linger for a few minutes. Here is that reminder of the CME code. I see, can we detect glycerol? Yes. I did not highlight glycerol in the interest of time, but yes, you can absolutely see that, most often seen in the setting of diaper rash and significant diaper cream use. Does come with lotions. I've seen that in older patients. I have not seen cannabinoid peaks, but that doesn't mean that they couldn't be there, and I just haven't been able to match them up with any sort of a database. So I think I caught the cannabinoid questions. Yes, so basically possibly unclear. Um, please add more questions. I'm going to scroll up really fast to see if I can capture anything. I love the participation throughout. Thank you, thank you. Oh, Peter Baker, thank you for the LIS variant. I think these were clearly annotated as pathogenic. So at this point, we're not concerned about a misdiagnosis, but that's great to know that there are assays for functional testing confirmation. Glycerol in slushies? Ugh, gross. Fun fact for anybody who's lingering, glycerol causes cross-reactivity with most core lab triglyceride quantifications. So if your triglyceride result is bonkers high, consider sending a urine organic acid analysis because that can differentiate triglycerides from glycerol. That is a really good tip if you're worried about glycerol kinase deficiency. Most Most clinics and hospitals have triglyceride quants. They most do not have in-house urine organic acids, but so that can be a easily accessible test to start your differential. Okay, I'm scrolling back up looking for any other questions. Yeah, that low excretor GA1 has made me paranoid for years. I don't think we ever did enzyme analysis on fibroblasts because the variants were clearly annotated and confirmed um, basically the diagnosis, everything fit. Um, yes, thank you, thank you. I have, again, happy to feature more questions. Thank you for all the comments. I was just scrolling back up to the top of the talk. We'll exit screen and hang
Yeah, I
out.
think we're at time, Anna. That was a great presentation. Thank you so much. I think we all learned a lot today.
Thank you.
Right.